So let's dive into a really fascinating story from the world of medicine. It's all about how a life-saving device can sometimes create a brand new problem. It's his incredible tale of innovation, of the body's amazing and sometimes surprising ability to heal, and really the constant battle to stay one step ahead. We're talking about something called instant restenosis.
Yeah, just think about that for a second. You have this tiny metal scaffold, a stent, that doctors place in an artery to hold it open, restore blood flow. It's a genuine miracle of modern medicine. But what happens when that very fix, that solution, becomes the site of a new blockage? Well, that's the big question we're going to unpack today. To really get our heads around this, we first need to take a little trip back in time. We've got to look at how we even got here. It's this story of constant evolution in the fight against blocked arteries.
It really all kicks off in the 70s with a simple but totally revolutionary idea: balloon angioplasty. You just inflate a tiny balloon to squash the plaque out of the way. Then, in the 90s, we see this huge leap forward: bare metal stents. These were like internal scaffolding, physically propping the artery open. And that brings us to today, where since the 2000s, we've had drug-eluting stents, basically smart stents coated with medicine designed to fight reblockage right from the start. Now, what's so cool about this is that it shows you this classic pattern you see in medicine all the time. Each brilliant solution fixed the biggest problem of its day, only to reveal a new, kind of more subtle challenge. The balloon solved the blockage, but the artery would often spring back. That's elastic recoil. So bare metal stents fixed that recoil, but then the body's own healing response created a new problem: neoentymal hyperplasia, which is basically scar tissue growing inside the stent. Then came drug-eluting stents, which were a game changer against that. But the challenge of instant restenosis didn't totally go away. And wow, this chart just brilliantly shows you the incredible progress. I mean, look at these numbers. The chance of needing another procedure within a year plummeted from a staggering 40% with just a balloon, down to 20% with bare metal stents, and then all the way down to around 3% with our latest drug-eluting stents. That is a massive, massive win. But, and there's always a but, right? That 3% isn't zero. And when you're doing millions of these procedures every year, it's still a really significant problem. And this is where we meet the villain of our story: in-stent restenosis, or ISR for short. So what is actually going on inside that artery? How can a metal scaffold, something designed to keep things open, get blocked up from the inside out? Well, the main culprit has this fancy name: neointimal hyperplasia. But the best way to think of it is just as the body's healing response gone a little haywire. When that stent goes in, the body sees it as an injury. So to heal it, it starts growing smooth muscle cells and this sort of scar-like tissue right through the mesh of the stent. In its effort to fix the problem, it accidentally creates a brand new blockage. And just so we're clear, this isn't some rare fringe issue. Treating ISR accounts for roughly 1 in every 10 coronary stenting procedures in the United States. Let that sink in for a second. 1 out of every 10 of these procedures is being done to fix a previous fix. And here's the tricky part. Even with our best modern stents, there's this lingering, persistent risk, about 1 to 2% per year, that a patient might need another procedure for that exact same spot. It's this low-level but constant challenge. And this is absolutely critical. People used to think ISR was a relatively benign issue, maybe causing some stable chest pain. But we now know that's just not the whole story. A full quarter of patients who show up with ISR are actually having an acute heart attack. It's a real emergency. Okay, so now that we know what this is and why it's such a big deal, let's dig into the why. Why does this happen to some people and not others? Well, the reasons can be pretty neatly broken down into 4 main buckets. And to make this super easy to remember, we can use a simple little mnemonic, the PPAS rule. It stands for patient, procedure, anatomy, and stent. Let's take a quick look at each one. All right, first P is for patient. These are factors related to a person's own biology, and the single strongest predictor for developing ISR by far is diabetes. But other things like kidney disease, the patient's age, and even how their body responds to the stents medication can all play a big part. The second P is for procedure. This is all about the technique, how the stent was actually put in. if it wasn't opened up all the way, or if it isn't sitting perfectly flush against the artery wall, these tiny little imperfections can create turbulent blood flow and become hotspots where that scar-like tissue is more likely to grow. Next up, A for anatomy. This is about the artery itself. I mean, trying to place a stent perfectly in a very small or a very calcified, crunchy vessel is just a lot tougher. The same thing goes for really complex blockages, like one that's right where an artery splits into a Y.
And finally, S is for stent. The device itself really matters. We know that older generations of stents had higher rates of this problem, and even something as small as the thickness of the metal struts can make a difference. Thinner is usually better. And in very rare cases, the stent can actually fracture over time. So you've got all these potential culprits: patient, procedure, anatomy, and stent. How in the world do doctors put together a modern battle plan when a blockage comes back? Well, the answer is that today's approach is anything but one size fits all. It's become highly personalized. And the crucial first step, the absolute starting point, is to use advanced imaging tools to actually go inside the artery and see exactly what went wrong. And I mean, this has become a core principle of modern cardiology. As one major consensus paper puts it, imaging-guided therapy is essential. It's just that simple. You can't fix the problem if you don't know precisely what the problem is. So once they've had a look inside, doctors are faced with this big decision. Do we put in another drug-eluting stent, or do we use a special drug-coated balloon? And that imaging helps them choose. So for example, if a patient already has layers of old stents, you really want to avoid adding a third. So a medicated balloon is often the way to go. But on the other hand, if the problem was a stent fracture, well, you need the scaffolding of a new stent to fix it. So you can really see the modern playbook laid out here, and it's perfectly logical. First, you get the diagnosis. Step 2, you image inside the artery to find the why. Step 3, you carefully prepare that area, maybe using special tools to break up the old scar tissue. And only then do you treat with the right tool for that specific problem, either a new stent or a drug-coated balloon. And of course, for the most complex, stubborn cases, bypass surgery is always that important final option. I mean, when you step back and look at it, we've come an incredible way, from those 40% reblockage rates all the way down to just a few percent today, and now we have these personalized tools to fix even those cases. It really shows you the power of understanding the why behind a problem. This journey from a simple balloon to imaging-guided, tailored therapy is just remarkable, and it leaves us with one final thought. What's the next frontier going to be? What's the next breakthrough that gets us even closer to keeping arteries open for good?